Hello, everyone. Welcome to the Culinary Medicine Interest Group podcast. Today, we have a special episode because we actually have two guests. We have Dr. Brown and Diane Lindsay-Adler from the Boston Children's Health Physicians Group and the Center for, I'll let them say the name because the acronym is long and I never remember what all the letters stand for. But they're going to be discussing some things about pulmonary health, particularly in the context of pediatrics today.
Shall I go ahead? My name is Diane Lindsay-Adler. I'm a registered dietitian nutritionist. I work for Boston Children's Health Physicians, primarily in the pediatric pulmonology division, and mostly seeing pediatric patients, but with many different diagnoses, including overweight, obesity, food allergies, cystic fibrosis, and also vent-dependent type patients that are severely neurologically impaired, that are often tube fed, all different areas of nutrition. And I'll turn it over to Amy.
Hi, everyone. So my name is Amy Brown. I'm a practicing pediatric pulmonologist with Boston Children's Health Physicians. I wear several other hats, including an assistant professor and adjunct associate professor at both the NYMC School of Medicine and this Public Health. In addition, I also work very closely with our program through New York State. We have a Children's Environmental Health Center that is a statewide effort of 7 coordinated centers, as well as our local center, which is the acronym that John was referring to, CEHCHV, which is the Children's Environmental Health Center of the Hudson Valley. And we do a lot of community-based research, and we'll talk about environmental exposures in general, but as a pulmonologist, one of our main environmental exposures for children is from the air that they breathe in. So that's really how I got involved with this work. But in particular, for the Culinary Medicine Interest Group, another major environmental exposure that can have either protective or adverse effects on children's health is what we ingest. So it's really important that we talk about this topic today and talk about how it can affect children, and in particular, children we'll focus on with pulmonary diseases. So with all that being said, I'll turn it back to John and we'll get started.
All right, thank you both. And you touched on a lot of things that we're going to cover today, but I'm going to start off by going back to something Diane mentioned with overweight and obesity in pediatric patients. And we know that overweight and obesity are risk factors for a long list of medical problems, but especially in children. And we wanted to ask, what are the most common things that you see in your practice? And what are the typical presenting scenarios? What symptoms you see first? What age, what degree of body weight or BMI do you start to notice that health issues arise?
Well, I have to say, unfortunately, I've seen even very obese 3-year-olds. In my practice, obviously, because I'm part of the pulmonology group, children often have asthma, which, obesity and asthma are all interrelated. But I do also work with some general pediatricians as well as endocrinologists. So kids can be sent to me because they've seen something called acanthosis nigricans, which is a discoloration of the skin and can show insulin resistance. Unfortunately, now we're seeing lots of children with elevated liver enzymes, like a high AST, ALT measurement in their blood, high blood sugar, hemoglobin A1C, and lipid levels. Especially, I see a lot of elevated triglycerides, which kind of shows me, to me, that means a big ingestion of processed, highly sugary, sweetened beverages or sweet foods.
So I think that leads really nicely into our next set of questions. Do you think beyond the very sugary foods, there are any particular dietary patterns that you see in your pediatric patients with overweight and obesity? And are any of these patterns more tied to pulmonary complications?
I do see patterns of ingesting and consuming a lot of highly processed, very palatable foods that are often inexpensive. That also ties into food insecurity because patients are, eating what they can afford to eat. And this can all feed into a lot of inflammation, which feeds into more asthma, more, chronic disease. So the pattern I see is, even in the schools, many schools, like, for example, for some reason, I notice the schools lunches that my kids are having in the Yonkers School District can be pretty much fast food, calorie dense, chicken nuggets, fries, breakfast for lunch, things like that, that we're trying to work on. And many of my patients get a free lunch. So that's what we're dealing with. So yes, the pattern, and a pattern of a lot of snacking. Parents don't really know how to set guidelines for structured meal and snack times, which I try and teach them. So there's just sort of like, people are busy, there's a free for all, kids are hungry. It's been COVID, kids are eating a lot more, they're snacking a lot more, they're stuck inside a lot more. So that's pretty much what we're dealing with right now.
That's so difficult. How do you think these problems can be addressed, and these dietary patterns and then the health problems that are associated with them can be mitigated?
I think nutrition education, obviously, I feel very passionately that that's key. I think it's really key to empower children and parents to understand what's healthy for them, and to understand that there are choices that they can make, that they can afford, to teach them tricks and tips about recipes, about lifestyle planning that can help them and their families to be healthier. Also, I really get involved with physical activity, with teaching about physical activity. It's a whole big package. And I feel like I have to address the whole family has to get on board. And it really, even beyond the family, the schools, the community has to get involved to help all these patients from, a very young age to learn and be empowered to eat healthier.
I also wanted to add to that, because everything Diane said is so important, but as we think about the clinical practice paradigm, something, and I feel so grateful for this all the time, having Diane, is really the importance of the interdisciplinary team and working together, and having a non-siloed medical practice, meaning that as the pediatrician who parents are often coming to see, we have to address, right? And so addressing a child pain is always very important, but sometimes the need for further counseling is often something that a parent may wish to discuss further during the visit. And sometimes we're constrained by time, we're constrained by our own clinical expertise. So having someone like Diane as part of the team, as part of the tribe member, is really just so important, because it allows us to work together and really do a comprehensive dive into these aspects that are so important to the health and well-being of children and families. And it also allows us to connect with our community partners. So some of the work that Diane and myself and other members of our team do is reach out to schools. We've gone into schools. So move the needle of discussion where that's happening from the office visit, but also in the community, bringing in community partners, making sure that schools have the resources available. So, to kind of summarize what's describing, just to really think about that we work in healthcare team and we can all work together to promote both preventive counseling for nutrition education, and then also the counseling for nutrition education if red flags such as obesity or a trend towards overweight or certain behaviors are addressed or noted.
Thank you. And I want to kind of circle back to something else that you mentioned in the beginning, Dr. Brown, about the idea of exposures and allergies as associated with diet, and how we've seen an increasing prevalence of pediatric allergies, especially to food, in recent years. And there's been a lot of research on that. And I want to ask, can you speak a little bit more what that looks like in your practice, what your thoughts are on the causes of this trend, and also its relationship to asthma and other hypersensitivity complications that we see with the pulmonary system?
Yeah, so that's a great question. And I want to get down into a few different parts. First, I want to just talk about asthma as this kind of asthmas, meaning plural, many types of asthma. And we can also go by the term phenotyping, right? So asthma is not just one disease. And there's a lot of discussion about specific asthma phenotypes that are the more allergic or Th2 mediated asthma responses that we classically think of. But interestingly, obese patients with asthma may have a different phenotype. And so there actually is an obesity asthma type that we talk about that has more of a Th1 response. And of course, there can be overlap, and no patient ever fits here in that box. But I think it's important as we think about asthma and we think about causes to separate out what the trigger is for these patients. Again, it may be multifactorial. Really understand that if obesity is the main trigger of this patient's type of asthma, of course, if we've excluded other allergic causes, then really that needs it to be our focus of counseling. It's important to be comprehensive and talk about allergy burden reduction, but really that is the treatment principle, is focusing on what is triggering their asthma. So the more we can phenotype and hone in on the type of asthma, the more we can provide targeted, effective therapy. So that was just one of the questions that you asked. Your question was this, the increased prevalence of allergies over the years and food allergies and how that relates to asthma. And so thinking about the patients who are not obese, but who have either allergies in general, we know that much of this has to do with the environment. If we think about allergies, a lot of this has to do with age of introduction. There's been a pendulum swing over the past 20 years and several studies that have come out that have suggested that perhaps delayed or late introduction, which was kind of the mantra of about 20 years ago, to delay introduction of allergenic foods such as peanuts, eggs, that should be introduced early, and delayed introduction may actually be harmful. Another thing that we know is that eczema and this concept of atopy, what we call its atopic march, is that we can now hone in on children who may be high risk for development of food allergies. And so one of the things we commonly see is that children who have early life eczema, who may be on the Th2 spectrum, are more likely to develop food allergies if they're introduced to food proteins through their skin barrier, because the skin and the gut both process allergens, but the gut is designed to process them in a way that promotes tolerance. However, young children who have eczema, who, for example, with peanuts, may be exposed to peanuts not through their GI system, but in their home environment through the skin, may be more likely to then go on. And there's several other factors, family history as well, but to develop food allergies. So we know that intact skin barrier is an important protective mechanism. We know that early introduction of allergenic foods is an important factor to address. And then we know that obviously there's family history and other aspects of genetics that will also predispose a child. How that relates to asthma is really in this area of atopy. So as we think about that atopic march, so early life, we see eczema, we see that insensitivity. A bit later on, we may see allergies. We may see that gut or upper respiratory, like rhinitis, presentation. And then in the toddler years, we often will see the asthma presentation, so lower waves. And that is something that we commonly see and address. And we can talk to about, anti-inflammatory diets, promoting healthy eating behaviors. But that Th2 phenotype is one of the more common that we see in the office. And again, I think of it as a distinct entity, to circle back to the original points I was making, than obesity as it's related to asthma. So I know I just gave you a lot of information, but just kind of wanted to highlight some of the trends and thoughts in allergy as it relates to asthma. The last piece that I'll mention is pregnancy-related habits and maternal diet. So we always think about the child and the risk factors to the child, but it's been studied and looked at, and there's a great paper in JACI, the Journal of Allergy and Clinical Immunology, that was published in 2018 that describes a lot of these findings. But one of the things it talks about is that maternal weight can be a risk factor for future childhood asthma. So again, this preventative education is important not only in the pediatric realm, but also with our OB colleagues, and as we think about adult medicine and how that interacts with future children. So just a lot of talking. I'll pause for questions and any comments from Diane on all of that, and I hope that in a roundabout way answered some of your questions.
Well, again, I think the answer to all of these issues really is a healthy diet and more fruits and vegetables. It's the bottom line for almost any of these issues that we're talking about. And I did want to mention that I do see more children now present with, the patients that are sent to me have peanut or tree nut allergies, but also a lot of milk allergy and milk intolerance and milk lactose intolerance in my patients. So I give them a lot of guidance about milk alternatives that are healthy for them.
That was so interesting. Thank you for sharing all of that. I want to pivot our conversation a little bit. We've now talked about a lot of pulmonary disorders. And I just want to ask, sort of in general, what other dietary considerations go into your practice with your pulmonary patients? And if you could touch a little bit on cystic fibrosis, which we haven't talked about yet, but we've learned about pancreatic insufficiency. And so we're curious how this relates to treating a pulmonary disorder.
Okay, well, I am part of the Cystic Fibrosis Center, the Armand V. Mascia, or the New York Medical College Cystic Fibrosis Center, and it has a team of specialists that help each CF patient. So we have a physician, we have a social worker, we have a dietitian, we have a coordinator, we have a nurse, and we're there for the CF patient. But a big component for most CF patients who are pancreatic insufficient is taking enzymes. I feel like our team, CF Center physicians, could be GI doctors because they're so educated on how to dose enzymes for patients. And, primarily we can tell they need more enzymes when we see it in oily stool. That's a question I ask all the time. I'm very open and honest. I talk about stool all the time, as are all our physicians. And that can be an indicator of weight gain or weight loss when their enzymes are not dosed correctly. Maybe Amy, you want to, elaborate a little bit more about the enzymes in CF?
Absolutely. So, enzymes are really the mainstay, and it's so important that our patients are able to maintain healthy weight, because the way I think of it, a patient with CF, their lungs are running a marathon, right? Their lungs are inflamed all the time, unfortunately. And, in 2022 with modifiers, the genetic modifiers that we can take, things have changed. But if you think about metabolic demand, these are patients who are always living at a higher metabolic demand. And then add a cold on it, which young children are getting all the time, and the inflammation that is dysregulated in their lungs. So as we think about how weight relates to cystic fibrosis, we think about the caloric needing much higher. But then unfortunately, because of the pancreatic insufficiency, it's hard for them to absorb those calories. So the enzymes are replacing what they're not able to absorb in their gut, but the baseline principle is figuring out what their metabolic demand is so that they can maintain that diet that will allow their lungs to not essentially consume their calories. The way I was trained, when we think about young children who may not be able to reliably do regular pulmonary function tests, their weight gain is a function test, assuming that we've done our job as physicians and the nutrition team of optimizing their enzyme intake. I will mention, and Diane, I'm sure feels the same way, this is very tricky with children, very stressful for parents. Hard enough to get your toddler to eat, let alone a healthy diet, let alone a high fat, high calorie diet for our patients with cystic fibrosis. So the counseling takes a lot of acceptance and understanding and empathy for what the parents are going through. And it's a really important thing that we work together and allow the parent to be honest and open with us with what they're consuming. Diane, I don't know, in your experience, but I find a lot that I often have my most intimate conversations with stress, that this is a high point of stress for parents to get their children to eat healthy, because especially with our patients for sleep, they know that that is a crucial modifiable factor that they can offer their children with regards to their lung health. So Diane, in your experience, how do you find that these conversations go, and find that these are time stress for your patients, especially with young children?
There's so much stress, and I think that it almost becomes a behavioral battle sometimes with the parent and the child, because the child knows how important it is for the parent that they're eating enough calories. I just want to throw in there that I always introduce, and the team is I think as well, starting to introduce the idea of a G-tube at a very young age, which is a enteral feeding tube into their stomach. Many cystic fibrosis patients can do much better nutrition-wise and weight gain-wise when they have a feeding overnight with the G-tube, and they can get in about 1,000 or more calories while they're sleeping. And it takes away the stress between the parent and the child about getting enough calories in. And we've seen many patients do very well this way when they get the G-tube put in.
Mm-hmm. And these are hard discussions. I mean, traditionally, the model of a G-tube is like a last resort, right? We're using it because they, and we're not talking about patients who can't feed by mouth. We're just talking about for supplements. And I have these discussions and we talk about it's a for now, not a forever thing. It does take a lot of stress off. Obviously, it can add a layer of stresses as well. But tube feedings and just maintaining a healthy weight are so crucial. One of the things that we commonly see is that, what we may use in a tube feed, such as a Pediasure supplement, sometimes the kids will drink them for calories and like them, but then that's used in place of healthy meals. So it's this fine balance of introducing supplements to children. But again, we're talking about a picky eater population potentially. And so we often find that, they want to have the chocolate Pediasure for lunch instead of lunch. So what is the balance? And Diane, how do you manage that balance of supplements with healthy meals, especially in younger children?
It's very difficult. And I often ask parents to give it at the end of the day when intake has been poor, because obviously as a nutritionist, I want them eating real whole foods all the time. And I find that a lot of the CF patients in particular sort of get really used to drinking 3 or 4 Pediasures a day. And, with so much else going on with the parents and all the medications and all the treatments, that sort of can happen. But now, and I'm sure Amy can add to this, with the introduction of Trikafta, which is a highly effective modulator, patients are becoming regulated, their mucus is disappearing, and they're becoming overweight and obese. So that's the challenge now with all the CF dietitians, is like sort of pivoting and working on weight gain with these patients.
Yeah, so this is so interesting. And had we recorded this podcast 10 years ago, this wouldn't be a part of discussion. And, practicing CF physicians and CF centers are becoming better equipped, but it's a discussion over the past decade of how do we now manage patients who are so used to high fat, high calorie diets. Now we're genetically modifying their CFTR function, optimizing it. Some patients are becoming pancreatic sufficient, even everything is just working much better, but they're used to a high fat, high calorie diet. And then we're seeing overweight or obese patients. And are we creating a new set of problems because we've solved another set of problems? And it's a really important dialogue, and one that for the students, this is going to be the future of CF, is now balancing overweight and obesity, which is something, 10 years ago, 30 years, many years in the past, I think providers would never have dreamed of, that they were going to have to discuss and address challenges of overweight and obesity in patients with CF.
Thank you. And I think that's a lot of really interesting points, especially considering, like you said, I know from other things that, 15, 20 years ago, the recommendations for CF patients was basically ice cream, peanut butter, and butter on every possible meal you could think of to try to just up the calories. And it's amazing how things have changed so much and we've come so far medically. And it's only been, 15 years since that was the mainstay recommendation.
Right, it's really incredible, and the patients are having a hard time getting used to switching over their eating habits. But we're also, just to mention, it's increased longevity, so much more of a risk for lipid levels going up, or heart disease, and all these long-term chronic diseases. So we're definitely, as a team of CF dietitians, which is sort of a nationwide group that we have, and we have a listserv. The conversation is ongoing about it, and I am awaiting new guidelines from the CF Foundation about all of this.
And one other thing to mention, and this could transition even into any pulmonary disease, is that, in order to move, so the lungs, obviously, I'm just going to do some physiology. The lungs are encased in the chest wall, right? Which is essentially the ribs but then there's everything that's on top of the ribs. And if you have an obese individual, the work that it takes to move the chest wall when there is an excess of fatty tissue on top of the rib cage is more work, and that's more calorie consumption, and that makes you less likely to be able to maximally expand your lung volumes. And when we think about all of our lung volumes, what we see is in the different parameters, you're still able to maintain that FRC, if you guys remember that term, the functional residual capacity, but the actual expiratory reserve volume, like the amount that you can get out if you took a really, really deep breath out and kept going, becomes so much smaller because you just aren't able to change your chest wall mechanics as efficiently. So there are a lot of studies that look at the pulmonary physiology, and this isn't unique to CF. We can see this in a variety of pulmonary diseases, but if you think of it simply, the weight on the chest makes it that much harder. And if you think about a patient with CF who's got inflamed lungs, so the airways inside the chest are already having to work that much harder, even if modulators have been taken, there could have been inflammation that had been there from prior patients with CF and some bronchiectasis. And then so trying to now add another difficulty, something harder to the pulmonary mechanics on another end of the spectrum on the chest wall can only create, again, another set of problems different than the classic problems that we are used to taking care of with cystic fibrosis.
Thank you. And to kind of wrap everything up that we've talked about, we've touched on a lot of different aspects of pulmonary health and pediatric health and diet in general. I wanted to ask you both, what are your thoughts on incorporating more nutrition education into the medical school curriculum and how you feel this is most effectively accomplished?
Well, I'll have to give a shout out to my profession and see if, I would suggest having a dietitian in every medical office, to refer to. And I think that's really key because physicians are so busy with all their, the other issues that have to be addressed. And there are now studies showing that regular visits with a dietitian are effective in helping patients consume a healthier diet and reduce their BMI. So that's my opinion. Amy?
Yeah, I couldn't agree more. I mean, I am so grateful for Diane, and I know I speak on behalf of our whole entire team. We could not do work without her. It is so crucially important. When we think about for food insecurity, the screening modality that we use is called the hunger vital sign. Nutrition, hunger, how much you're consuming, that's truly a vital sign. That is crucially important to address. And when we think about it from a public health perspective, addressing nutrition from an education by educating healthcare providers, by having preventative discussions with parents, that's a more upstream approach, right? So we can counsel when a patient is identified as high risk and they're already obese. But John, to answer your question, like incorporating that into medical education, incorporating that into clinical workflows where it happens upstream is so critically important. If there's anyone who would say we don't need it downstream, we desperately need it downstream after we've identified them as having a disorder linked to their nutritional intake. But I think our challenge and what Diane and I and our whole team is excited to work with you and the School of Medicine on is how do we put that more upstream? How do we incorporate that into providers, into clinical teams, so that addressing that in a preventative approach at every visit? So we're just excited to be involved in this conversation. We think this work is so crucial. And again, it's done in teams. And so I'm just grateful that we were able to do this in a team today, and for all of our nutritional support that we have in our pulmonary program.
Me too. And I love my team as well. And I love that we have an interdisciplinary team to address all these patients with obesity in particular, but also our cystic fibrosis patients. and that I have the opportunity to work with all of these patients. It's been a great learning curve for me. And I look forward to maybe working with you guys again on any different topics that you want to learn about.
Well, thank you both so much. I know that as students in the School of Medicine, we are also all so grateful to be involved in this initiative and to be bringing this very important work to light because it's the future of medicine. And we like to close out here on the podcast with a little bit of a fun question. So I'll just ask of both of you, if you were going to present a dish on MasterChef, what would you choose and why?
I would choose chocolate lava cake because I love chocolate.
I love that answer.
And I would make banana bread because my kids, the mashing of bananas, that's like their favorite thing to make. And I feel like we can never have enough homemade banana bread in the house. So that would be my
Yummy, I'm hungry now.
Well, thank you both, Dr. Brown and Amy, for taking the time to talk to us and share a lot of really interesting perspectives on pulmonary medicine and how it interacts with pediatric health and obesity and overweight and allergies, hypersensitivities, all of those things. So thank you both very much for your time. We really appreciate it.
Thank you so much.
It was our pleasure. Thank you for organizing this. And we look forward to continuing to work together. Great job.